laser surgeries, especially retinopathy of prematurity, think about the small eyeball. And if you want to look into the periphery, we have to look at 270 degrees. Just think about this just for a second. We have to look at 270 degrees. So that means that I have to be moving 270 degrees to look at different quadrants. So we try to rotate the eyeball, try to rotate the eye, but there's a limit to how much you can flex and you can bend your head. So a lot of times that you have to do this. And that's why it's so dangerous. Okay? And then, is there anything we can do? Yes. Yes. So, I don't know if you actually saw my surgical loops today. Did you see my posture? You remember how I was always like straight up? I didn't say a word today, but I just wanted you to think about that, right? I was always like straight up. I didn't bend at all. So there are these surgical loops and also these vases that were developed, believe it or not, 100 years ago. These loops that a lot of the doctors are using was developed 100 years ago. Okay? And it's horrible. And so this is what it looks like. I actually have it with me in my bag. So it actually has a prism built in. No, it's not working anymore. So anyway, as you can see, it's bent 45 degrees. So I'm actually looking like this, and I'm working with my hand like this. You understand? You saw that today, right? Okay. So that is something that I want you to think about using, especially if you're having discomfort, any type of discomfort whatsoever. I have no financial interest. Okay. And this is the traditional surgical loops right here. And this is the new loops right here. Okay. All right.
Your invention, right?
It's part of it's actually one of my inventions also. Okay. And then the instruments. Make sure that it's sharp. I was actually doing a lot of unnecessary movement when I was doing this surgery. So make sure you talk to your surgical technicians who prepare these instruments. Make sure they sharpen your instruments. It's just like you going to a war with a weapon that doesn't work. I mean, just imagine that. You understand? Like going to surgery is almost like going to a war, because things can go very badly. You're just like one step away from a disaster. You understand? I mean, so if things go well, it's great, but unfortunately, things do not go well. And the reason, some of the reasons why the things do not go well is because you don't have the right equipment. That's the majority of the cases, actually. And you're trying to improvise, like you don't have the right equipment, so you try to be a MacGyver and trying to come up with different movements or different maneuvers to improvise, but it sometimes can backfire. So something like scissors, you really need to get it sharpened. You understand? Okay? Because that will hurt you if you do this over and over. And also, make sure you adjust your chair appropriately. And I'm sorry to tell you, the chairs in the OR needs to be replaced. I'm going to tell the directors right now. You need a chair that can go up and down. Not the one that you have to like do this. No, please. You guys are the National Eye Hospital. You guys deserve, with the amount of surgeries that you do, I'm going to tell you, by you just simply doing this, I bet you could do 2 more cases in a day. Okay? That will make your job so much easier. And these great doctors will be able to work 2 more years. I mean, just think about that. You know, you really have to take care of your own people. Okay? So the chairs, please, I would highly recommend it. Okay? And then, please also, these microscopes, I'm going to tell you, when you have a right chair, you can go up and down to adjust it, but when you don't have a right chair, then what happens is that, remember, the microscope is set, the chair is set, only thing that you can adjust is yourself. So you're like, you know, operating like this. And I saw them today. Please don't do that. That's going to hurt you in the long run. And you know, you guys are very important. So please do this. And then there's a 3-dimensional devices that's coming out. And as you can see here, there are 4 doctors trying to do surgery on one small area. But now, there's a 3D devices. We're pretty far away from this. This is very expensive, and it's, I've used it before, but it slows down the turnover time. You guys are doing cataract surgeries in 5 minutes. This will prolong it for another 30 minutes. Okay, I don't think it's going to be very feasible, but for what it is practical, it's like simple thing as a chair. Okay, so I actually do use this, and it's great. It's fun to use, but it's not practical for most people because it takes up too much space in the operating room. Okay, so 4 take-home messages. If you could please remember this. Number 1, have your nurse take video of your postures. And then just look at it for 5 minutes. Tiger Woods, who's a golfer, has a coach watching him every single day. I mean, just think about that. Even Tiger Woods has a coach telling him your posture is changing. So you as a professional, you need to watch yourself. So have someone just take a video of you for 5 minutes and just see how bad your postures are. And I'm going to tell you, you'll be shocked. Okay? Number 2, between cases, you guys are going very fast. That's okay, but you still have a couple of minutes. Make sure you stretch between cases. Please, please do. And have a bottle of water between cases because that disc needs to be hydrated. Because what happens is that when you're in a bad posture for a long time, you're squeezing it and you're dehydrating it. And that's why you're increasing the chance of herniation. You understand? Please, please. I really hope that you take this to heart because I'm going to tell you, in your lifetime, you'll hear thousands and thousands of lectures. And for my 3 lectures today, I really hope you take it to heart. Because the next 2 lectures is going to be very important too. Okay, next, consider like a prism glasses or surgical loops that will improve your posture. Just think about it, and they will come to you. Actually, these things are not cheap, so they will come to you and have you try it, so at least you will know what it feels like. Okay? And I personally think that is worth your vacation. And then also, as you get older, whether you like it or not, your body changes. We all get shorter. So glasses that used to work 10 years ago is not going to work today. Remember that, okay? And then lesson number 4, this is the most important. It is okay to complain and cry. The surgeons, we have this mentality that, being in pain is like a badge of honor. You understand? You're tough. You understand? It's like a soldier mentality. No. When your body's in pain, your body's telling you something is not right. Don't ignore it. Don't go home and take aspirin or like pain medication. You're just trying to cover up the problem. No. Get to the source of the problem. Just don't cover it. Don't cover up the problem. And this is my favorite quote. There's an island in South America called Galapagos. And this is where Charles Darwin visited, and he came up with the idea of evolution. And he says, when you go to this Galapagos Island, there's a huge sign. He's not the strongest. He's not the smartest that will outlast you. He's the one that's adaptable. That will outlive you. It is so true. It is so true. You have to be adaptable. Thank you. Any questions? Any questions? You guys understood all that?
I have one question first relating to tear of the muscle. local anesthesia, then the muscle is stopped. And in that case, we stop and we change the patient into general anesthesia, and then we are looking for the muscle or not, because the risk of the cardiac complications.
Also, are you saying that the oculocardiac reflex, is that present under general anesthesia also?
Yeah.
Yes, oh yes,
No,
yeah.
I mean, in case we do the surgery under the local anesthesia, it means that the patient still awake. And should we change to
Sure, okay.
anesthesia first?
The question is that if you have a torn muscle or a pulled in two syndrome while you're doing the surgery on the local, should you convert to a general? I'm going to tell you the chance of that happening is virtually zero. The reason for that is that when you're doing under local, you can't pull on that muscle too hard because the patient's going to be in pain. Yeah. So the chance of you tearing the muscle is very, very small under local. I've actually never seen it happen. It's usually these patients are under general, and the assistant just doesn't know how hard to pull. Yeah. Okay. But I don't think I just never seen a local anesthesia resulting in a slip muscle, in a torn muscle. Okay. Okay. Next talk. I think I'm going to talk about. Okay. I have till 2 o'clock, right? Okay, right? Yeah, thank you. So next case is, I have actually a lot of interesting cases, but I'm going to talk about a particular case that we have a special surgical technique that we have developed for this. So here's a patient who's a year and a half who comes in. Patient is able to fixate and follow, but has a chin-up posture like this. And when patient tries to look up, the eyes look funny. Okay. So what is the most likely diagnosis? So patient cannot look up in a young child, and it's congenital. Diagnosis? Anybody? Okay. This was Brown syndrome. Okay. I'm going to talk about Brown syndrome in just a little bit. Okay. So I'm going to talk about what is it, when to operate, and what is suture spacer. Okay. Number one is that in order for someone to have a Brown syndrome, there are 5 criteria that has to be met. 5 criteria. Number one is that they have to have limitation in elevations and adduction in the involved eye. Okay. And then also, when they look the opposite direction, it's almost normal. And then, when they try to look up, it actually has a V pattern. V pattern. So they almost develop exotropia, but then when they look down, they converge. Whenever I say V pattern, usually it implies that inferior oblique muscle is overacting. Because remember, we talked about this yesterday, when the eyes are axocontorted, like when the eyeball is axocontorted like this, and the eyeball is moving up, is going to diverge in both eyes like this. So they're going to have a V pattern. But in this particular patient, they have insacotorsion. So when they look inside the eye, they have insacotorsion, almost as if this is a superior oblique overaction. So they have an intorsion with a V pattern. And this is the only condition that causes that. Okay? So when you look inside the eye, the eyeball is insacotorted. And then on top of that, when you do a forced ductions test, the superior oblique muscle is tight. Okay? So this is so that's how we make the diagnosis of the Brown syndrome. And then, of course, the forced ductions test is the key. So there are congenital cases and there are acquired cases. And there are different theories. It was first described in 1950, and initially it was felt that the superior oblique tendon was too short. But then later, Gene Halveston said, no, it probably is not too short. but it's the elongation mechanism that's not working, like a telescope. When you have a telescope, and if you cannot stretch the telescope because it's stuck, then that could be like a Brown syndrome. So it's just like elongation mechanism doesn't work. Okay, you understand? So, but there are many different causes of Brown syndrome. I'm going to just talk about, there are so many different things that can mimic the Brown syndrome. For example, the Brown syndrome, the tendon can be too short or too large, or the tendon is not going through the trochlea for whatever reason. Because let's say you have a nodule along the pubic tendon that is preventing that tendon from sliding through the trochlea, then the eyeball, the patient's not going to be able to look in certain directions. Okay? Okay. But there's no one diagnosis, one mechanism that can explain everything. So I'm going to actually do a little short demonstration real quick. Okay. Can I have a chair right here? And then I'm going to have so this is, sorry, it's a little warm. Okay. So imagine that this is my right eye. Her eyeball is my right eye. Okay? This is my right eyeball. And so let's imagine what happens if this pubic tendon is tight. Because remember, pubic muscle, just like all the other muscles, should be elastic like a rubber. Should be like a rubber, right? But let's say this pubic tendon, instead of being rubber, is like a leather. It's like stiff. Okay? So let's just imagine it for a second. Okay. So if this is my right eye, this is the tendon that's attached like this, right? So my elbow is the trochlea. Can you come over for me? Sorry. So my elbow is trochlea. Can you hold it like this? Okay. And the insertion of this pubic tendon, remember, is lateral and posterior, just like this. And that is the reason why the primary function of the pubic tendon is insacrotorsion, is intorsion. And then secondary function is depression, you see? Makes sense, right? And then the tertiary function is abduction, because remember, it's attached posteriorly, so it's going to go like this, you see? So it's insacrotorsion, depression, and abduction. Simple, like that. In order for this to happen, this tendon has to transverse through the trochlea. Like, remember, it has to shorten and lengthen. Does that make sense? But let's say, for some reason, there's a nodule right here that's preventing the tendon from moving it back and forth. Or, let's say you have synovitis, a synovial fluid problem, and there's a problem with the trochlea, and you have trochleitis. And you have pain in that area, like right there. Okay? And so, acquired cases of Brown syndrome, they'll say, Doc, I have a pain right here and I can't look in certain direction. So those are the acquired cases of the Brown syndrome. And you give them steroids and they get better for a while, then it comes right back. So what happens is that if this is tight and does not elongate, and let's imagine what would happen if she tries to look up. Try to look up for me. Move your head all the way up. It can't. You understand? It cannot. Especially when she's looking this way. Remember, this is my eyeball. When this is looking this way, that's going to elongate the tendon the most. You remember, it's over here. And when she's looking this way, the tendon is going to be elongated the most. And because this tendon is short, she is not even going to let her look this direction. So when she's looking this way, her eyeball is going to be looking down. Does that make sense? But when she's looking in opposite direction, like this, remember now this tendon is not going to have, it's going to be, remember, it's under a lot of tension, but it does not need to be elongated. So that's why she's going to be able to look in abducted position, looking up, but she's not going to be able to look up in this direction. Does that make sense? Okay. Now, why is this important? Okay. And what does that got to do with the force reduction test? Okay. So here, can you do the same thing for her? Okay. So show her. Okay. Let's see. Use your left arm. It's okay. So like this. So force reduction test. So I'm going to be grabbing. Remember, this is my right eyeball right here. I'm going to be grabbing onto the eyeball, like right here. And in order for me to, remember, I'm trying to determine whether the tendon is stiff or elastic. So when I say +1, +2, +3, +4, all I'm saying, all I'm trying to tell you, like when I say the patient has a +4 superior oblique, what that means is that that tendon is very stiff. It feels like a plastic. If it's +1, it does stretch, but it doesn't stretch as much. That's all it means, +1 through +4. So in order for me to test something, whether it's loose or tight, I have to put that tendon under the most tension. You understand? If I want to know how tight the rubber band is, I have to stretch it to a certain point before I stretch it further. I can't just like try to see if it's elastic or not when the rubber band is like this and I hold it like this. I have to stretch it out. So I have to stretch out the tendon the most before I can tell how tight it is. The way you do this is that you grab onto the eyeball and you're gonna push it back. You're gonna retropulse. Does that make sense? You're going to push it back. Before you do anything, if you want to tighten, come over for me. If you want to test this pure rectus muscle, what you're going to be doing is that you're going to be doing exactly the opposite. You're going to pull the eyeball forward to put this tendon under tension before you start manipulating. Okay? Okay. So let's do this again. So here. So what you do, watch this, okay? You hold the nasal portion of the cornea, or the limbus, and you're going to retropulse as much as possible. Now the tension, these tendons are going to be under a lot of tension now, right? Then you're going to rotate the eyeball. So the way you rotate the eyeball is that when you rotate this, when you rotate this, I'm going to rotate it counterclockwise. Watch what happens. When I rotate it counterclockwise like this tendon is going to move from this part to the opposite part of the crest, the equator. You understand? So the crest is the area that's the steepest, if you will. So the tendon's going to roll from this side to the opposite side. So by you pushing it back further, you're just basically trying to feel this bump. That's what you're trying to feel.